Tēnā koutou katoa, and welcome again to the Hospice New Zealand Breakfast webinar held in partnership with My Health Hub. The presenter this month is Dr. Steve MacFarlane, Associate Professor of Aged Psychiatry at Monash University in Melbourne. Steve graduated from Monash University in 1991. He became a psychiatrist in 2003 and was appointed Director of Aged Psychiatry at Peninsula Health in 2005. He moved to Alfred Health in 2008 as Associate Professor and Director of Aged Psychiatry before accepting a position as Head of Clinical Services with Dementia Support Australia in 2016. Steve is a past chair of the Faculty of Psychiatry of Old Age for the RANZCP and has been running Alzheimer's disease clinical trials for over 20 years and has clinical interests in frontal lobe disorders and senile squalor. His work with the DSA has him overseeing a group of geriatricians and old age psychiatrists around the country. He has been intimately involved in developing the new Commonwealth Special Dementia Care Programme and with the Royal Commission into Aged Care Safety and Quality, testifying before the Royal Commission in May 2019 and July 2020. And his topic today is palliative care for people with dementia. Despite dementia now being the leading cause of death in Australian women, fewer than 2% of those with dementia receive special end-of-life services. Why is this, and what can be done to change it? Thank you, Steve, for joining us today.
Not at all. Thank you for the invitation. I think it's been about 3 years since I spoke to this group. I remember getting up early in the morning once before in 2018 or something like that. So apologies to those of you who may have heard elements of this talk before, but I believe there's more attendees today, so this will be new to at least some of you. I'm not a palliative care physician. I'm an old age psychiatrist, as you heard, and I really first became interested in the issue of palliative care for people with dementia during my work with DSA. DSA is a national service, Dementia Support Australia. It's funded by the Commonwealth Government, and our brief is to go into nursing homes and help staff manage people with significant behavioural disturbances. And we disengage when the behaviour has settled, but a couple of years ago, we started asking the question, what happens to people after they leave our service? Do the behaviours recur? What's their ongoing trajectory? We had some data from the early days of the DSA service when we found that in a branch of our service called the Severe Behaviour Response Team that deals with really the most severe behaviours out there in nursing home land, we found that about 10% of the people who were referred to the Severe Behaviour Response Team actually died during their episode of care. And that led us to think, are we missing something? Have these people actually been referred with significant behaviours related to dementia, or are the behaviours with which people are being referred indicative of the dying process in that group? So as time wore on and our data set and resources expanded, we decided to explore this question more fully. And a couple of years ago now, we went through the exercise of following up about 250 people who had been through our service. They had an episode of care, their behaviours had resolved and they were discharged. But we went back to the nursing homes that they resided in about 3 months after their episode of care finished, just to see what happened to this group of people. And we were amazed to find that within 3 months of discharge from our service, 30% of people were dead. Which is a horrendously high number. We'd like, of course, to think that they're not dead because of their involvement with our service. We're a non-pharmacological behaviour management service, so we don't tend to poison people with antipsychotics and so forth. But with 30% of our clientele dying within 3 months of their case closing, it did bring this issue to the fore once again. Are people being referred with terminal agitation, which has gone unrecognised, rather than with the behaviours and psychological symptoms of dementia? So as a result of those observations a couple of years ago, we've now started to do a palliative care pilot informed by some of the work that I'll present in this talk here, which is hoping to allow us to proactively identify those people referred to us with behaviours related to dementia who may in fact be dying, and to try and link that group of people in, if we can identify them, with appropriate palliative care services in Australia. And we have found, and we have identified people that we do think are on a permanent trajectory, that local palliative care services are actually reluctant to pick them up, which again is a concern. But in response to that, as part of our pilot, we've actually engaged a palliative care physician based in Sydney, who can liaise with the person's general practitioner about appropriate pharmacological management of their distress. And it's really important that we do pick these people who are in the process of dying, of actively dying, because the philosophy of our service for managing dementia-related behaviours is to pretty much use pharmacology as a last resort. Once you realise somebody's on a terminal trajectory, your attitude towards the use of medications that might be considered chemical restraint in the setting of dementia actually changes, your mindset switches, and you move towards a true palliative approach. So picking this subgroup of people who are approaching death becomes really important for their quality of life and their appropriate care in the last few weeks to months of their lives. A brief plug for the Palliative Care Handbook, now I think in its 9th edition. Hammond Care, the organisation who runs DSA, is an aged care provider in Australia, and they have their own printing and publications arm. Many of you will recognise Rod McLeod's name as the lead New Zealand author of this book from the 1st edition onwards. I made some contribution to the 9th edition, specifically adding material on palliative care in dementia, which, after 8 editions of the textbook hadn't got a mention at all. So we're trying to raise the profile of this issue, and we're hoping that by attending this talk this morning, you might start thinking about the issue of how to identify approaching death in people living with dementia, and that once there's greater knowledge and expertise around this particular skill, gaining broader access for people living with dementia to mainstream palliative care services, because currently they don't seem to have it. And there's probably a number of technical and clinical problems in trying to determine when somebody is in fact dying with dementia rather than dying of another cause. We see increased behaviours as part of the picture of terminal agitation in people living with dementia, but we also see increased behaviours very commonly in people with dementia who aren't in the process of dying. In fact, BPSD, or behaviours and psychological symptoms of dementia, are very common. I've quoted the figure of up to 90% of people with dementia having these altered behaviours at some point during the course of their illness. The figure may be even higher. I've heard some sources quote up to 95% of people with dementia having problem behaviours. And the difficulties that we have in differentiating terminal agitation and the need for palliation is that terminal agitation in the setting of dementia just look like any other cause of delirium. And we know that people living with dementia are very vulnerable to delirium because the presence of pre-existing cognitive impairment is in itself the biggest single risk factor for delirium. So by definition, if you have a dementing illness and your cognition is not enough to keep you oriented to your environment at the best of times, it doesn't take much in terms of a physiological or environmental trigger to tick somebody over into acute confusion. So we have this overlap between BPSD, the dementia-related behaviours, overlapping with behaviours that are commonly seen in delirium, overlapping with symptoms that might suggest a terminal agitation. So there's sort of 3 clinical issues to tease out. What's BPSD, what's a non-terminal delirium, and what is a terminal delirium? When you look at the residential aged care population, if you can imagine a higher risk group of residents for developing delirium, you'd struggle to find it elsewhere outside of long-term care. We know in Australia that 50% of aged care residents have a diagnosis of dementia, we know that there's another 20% of residents in long-term care who have dementia, but it's not been diagnosed yet. So, you've got a concentration of the people who are vulnerable to delirium in aged care. We know that delirium is very common in certain groups of people. If you were to look at general medical wards in tertiary hospitals, you'd find that up to 30% of general medical inpatients as a group have delirium at any one time. So it's very common in acute medical settings. We don't know how common delirium is in long-term care. The studies haven't been done to my knowledge, but presumably because of the vulnerabilities of this group, I'd imagine there's a very high baseline rate of delirium in residential aged care residents anyway. Picking delirium is one thing. We look clinically for a recent, an acute or a subacute change in behaviour, cognition and function. In Dementia Support Australia, we probably find that about 13% of our referrals have delirium as a contributing factor. Most people recover from delirium. It's usually not fatal, but it's frequently recurrent because the risk factors don't go away. The other clinical problem with delirium is, although we do an organic screen and look for common reversible causes, even if we look, we don't find a cause of delirium in up to 40%. So is it that group who are perhaps more vulnerable to pursuing a trajectory of terminal agitation, and the diagnosis only becomes obvious in retrospect, by which point it's too late? So there's a number of clinical problems in differentiating different conditions with different prognoses that look pretty much exactly the same. And that's the clinical dilemma that we have. And that's perhaps why we were so surprised in DSA when we found that 30% of our clientele passed away within 3 months of discharge. So what's the state of play currently with access to palliative care services for people living with dementia? There's a paucity of articles out there. The most recent and relevant one that I could find was from 16 years ago, an article on access to specialist palliative care in Western Australia. And this article found that less than 1 in 10 people who died of non-cancer conditions received specialist palliative care. So that's the first point. Palliative care services seem specifically targeted towards people with cancer-related diagnoses. And if you don't have cancer, you've really got a very small chance, in Western Australia at least, of receiving specialist palliative care. So that's any other condition apart from cancer. So if we were to try and narrow the question down specifically to people with a diagnosis of dementia and their receipt of palliative care, firstly, some stats about dementia. In Australia, there's probably in excess of 450,000 people currently with the condition. For about the last 3 years, dementia has been the commonest cause of death in Australian women and the second commonest cause of death in Australia overall. Yet we know from overseas studies that in America, for example, and this is again 25 years ago, only 1.5% of people with end-stage dementia receive palliative care in the USA. And if that sort of statistic is mirrored locally, we've got 1.5% of people who die of the commonest condition leading to death in Australia receiving palliative care services. Is a big unmet need. European data, slightly more recent, looking at hospice patients, found that fewer than 1% of people receiving hospice care are receiving that care for any neurological disease. So neurological disease, of course, is much broader than dementia as such. You might imagine that a fairly high proportion of those receiving hospice care for neurological disease are receiving it for those progressive neurodegenerative physical conditions that leave your cognition intact. But these numbers are really striking about the gap in care for people living with dementia, or dying with dementia, in fact. So why is this the case? There's been a number of theories. One is that people who are experiencing terminal agitation in the setting of dementia are exhibiting a set of behaviours that actually might serve to exclude them from appropriate admission to hospice care. In other words, hospices and palliative care services are seen as places by patients and families where people might go to peacefully be palliated for the last few days of their lives, and other patients receiving palliative care, other family members, and possibly even staff within palliative care services are not possibly keen to have people with extreme behaviours in that setting. So the behaviours that might indicate the need for palliative care in this group might actually serve to exclude them from access to the care that they need. There are other reasons beyond not wanting the other patients or families disturbed, which at the end of the day is a stigma issue. Other reasons might include the fact that many people working in palliative care don't actually have dementia-specific skills. That's by no means a slur on people who practice palliative care, because the lack of dementia-specific skills is pretty much universal across all doctors and nurses, basically, unless you have specialist training in aged and dementia care. Certainly the staff who work in residential aged care, for whom you would think dementia might be core business, have a lack of dementia-specific skills. We've recently been through a Royal Commission into aged care in Australia, and one of the many recommendations that came out of that was to upskill ground floor level residential aged care workers in dementia, because currently you can work in a nursing home after completing a 6-week online course for which dementia is an optional module, despite 70% of people in aged care having it. This lack of dementia skills in aged care is perhaps mirrored by the fact that I mentioned earlier, 13% of DSA referrals have delirium. We determine that. It's not being picked by the residential aged care staff. In terms of doctors and nurses and their generic dementia skills, they are very poor, I'm ashamed to say. I teach fourth-year medical students from Monash University, and in their 4th year of medical school, I give them the first and possibly only lecture they have on dementia. And when I made inquiries through the College of General Practitioners about what subsequent training GPs get in their specialist fellowship to become general practitioners, I basically received the answer from the college that the training in dementia is, quote unquote, basically limited to what they got in medical school, which is 1 lecture. So GPs don't know much about dementia. What they do know relates to prescribing rather than non-pharmacological strategies. And they don't know much about palliative care either. Not many doctors do. The same, I'd imagine, though I can't speak for the system in New Zealand, might be true of nursing and allied health staff. I can't imagine that if doctors only get 1 or 2 lectures on dementia in their course, that the undergraduate nursing curriculum equips nurses adequately to work for people living with dementia either. So this lack of dementia-specific skills, not a criticism of palliative care staff, it's a criticism of our education and training for our health professionals. Perhaps the biggest problem, if we're being charitable about the situation, is to acknowledge the fact that identifying the end-of-life stage in dementia is problematic. I mean, the cancer literature emphasises that behavioural symptoms do occur in the last few days of life as part of this picture of a terminal agitation. But in dementia, the dying process may be quite prolonged, and it might be drawn out over several weeks or several months. And knowing when a set of behaviours represents impending death versus delirium versus generic behaviours associated with dementia is the clinical conundrum. And we're not good at predicting when end of life in dementia might occur. We should be, because there's research out there that shows the prognosis of people with severe dementia who are discharged from hospital into residential aged care. And we know what the average life expectancy of somebody going into long-term care is. So a number of studies that illustrate the very high 6-month mortality of people with severe dementia show that if you've got severe dementia and you go to hospital with either a pneumonia or a hip fracture, your 6-month mortality following that hospital admission is over 50%. compared to much lower mortality rates if the same illnesses occur in somebody of the same age in the same setting, but without dementia. So dementia itself is a poor prognostic indicator, and over half of those who have pneumonia or a hip fracture will survive for longer than 6 months. As an aside, there seems to be a myth that people with dementia don't experience pain either. From the same study in 2000, one of the findings was that about only a quarter of those who were admitted to hospital with a hip fracture and a diagnosis of dementia were prescribed regular analgesia, which again is surprising and somewhat shocking. Other studies about prognosis and mortality over longer periods of time. Mitchell's done a lot of this work in this area. He found greater predictors of mortality for various conditions occurring over 18 months, but we've listed here the 6-month mortality for a variety of clinical problems in the setting of dementia. He found that any case of pneumonia had a 6-month mortality approaching 50%. Any episode of fever, regardless of the cause, a febrile episode in a person with severe dementia in aged care, 44.5% died at 6 months. The development of eating problems, in particular associated with consequent weight loss, 6-month mortality approaching 40%. And he found that of those with dementia who did die, over 40% of them underwent a burdensome intervention in the last 3 months of life. And what he means by a burdensome intervention was a hospital transfer, or more commonly in aged care, a transfer to the emergency department, following which somebody gets loaded up with haloperidol and sent back. And perhaps if we were better at identifying this group of people who have a very high 6-month mortality and diverted them towards palliative care services, rather than sending them to hospital for acute behavioural disturbance, the outcome might be better for the health system as a whole in general, and certainly for the patients themselves in particular. So people with long-term care, people in long-term care don't do well. The average life expectancy for anybody in Australia, at least, who enters long-term care, regardless of why they go in, is about 2 years. That's the life expectancy once you enter. If you look at some general figures about nursing home residents, those who had various distressing symptoms at various intervals before their death. This work again comes from Mitchell. He looked at 22 residential care facilities in Boston, so over 300 patients. And this is where we found that pneumonia, a febrile illness, and eating problems all predicted very high 6-month mortality. You can see from the various heights of these bars, this is 9 to 12 months before death, 6 to 9 months before death, 3 to 6 months before death, and 3 months before death. You see increasing rates of symptoms such as dyspnea, which in the physical world of medicine, we can recognize as a potential sign of impending death and that people are struggling physically. We see increasing rates of reported pain as we get closer to death. We see increased rates of pressure ulcers, aspiration, but a fairly constant rate of agitation. And again, this raises the problem when you have somebody who has a diagnosed dementia who is agitated. You don't necessarily have these physical markers of agitation, pressure ulcers, pain, dyspnea, fever, whatever. They can be agitated for 12 months prior to death. So using these physical signs as a marker in dementia, in physical illness is fine, but in dementia, the presence of agitation is non-discriminative because we see this so commonly as a symptom in generic dementia. These predictors, again, just in graphical form here. I don't think we mentioned, or we did mention hip fracture before here, 55% 6-month mortality. These are all things which might point us towards a group of vulnerable people who, if they are referred with behavioural disturbance, can we use the occurrence of these particular clinical events as predictors of the need for palliative care? I mentioned earlier the pilot that we're doing in Dementia Support Australia. We've taken the work of Mitchell and others, and we're trying to incorporate this knowledge about proximal serious medical events, whether it's hip fractures, pneumonias, aspiration, loss of weight, or whatever, to try and identify people referred with behaviours who might benefit from palliative care because of terminal agitation. Diverting again from dementia into sort of general indicators of the need for a palliative approach in any condition. Many of you will be familiar with the gold standards framework that was put out of the UK in conjunction with the Royal College of GPs in the UK. They produced a helpful flow chart about the potential need for palliative care in any patient in general practice in residential care. And, a key recommendation was to reflect on the surprise question, which is, as a doctor or a nurse, to ask yourself, would I be surprised if this person were to die in the next 6 months, for example, or 3 months we use in DSA. If the answer is no, if you wouldn't be surprised, you'd then look for those general indicators of decline, which in the setting of dementia might be recent hip fracture, recent hospital transfer, recent febrile illness, recent episode of pneumonia, and begin contemplating whether or not the behaviours that a person's been referred with actually might represent a terminal decline. So this work informs the pilot that we're doing in DSA as well around palliative care and terminal agitation. When we're talking about this clinical entity of terminal agitation, there's a number of principles to be kept in mind, which are not necessarily exclusive to the management of dementia at the end of life, but the family and the patient need to be involved as much as possible. The family's goals for somebody with altered behaviour in the setting of dementia might be quite different once they know that the person is in the process of dying. They might prioritise quality of life and being engaged and ambulant if this was just a dementia-related behaviour. But once they're aware that the behaviour is an indicator of impending death, their mindset may well shift to wanting the person to be just comfortable and sacrifice their ability to communicate and to be alert for that benefit of comfort in their final days. The non-pharmacological management of terminal agitation is pretty similar to the non-pharmacological management of any delirium. And in DSA with our pilot, we have a number of dementia consultants who also have specific training in palliative care. They have palliative care backgrounds, and we are well used to managing delirium symptoms non-pharmacologically. Where the difference in delirium differs in terms of a terminal delirium is that the general rule in a garden variety delirium is that you should only use psychotropic medications as a last resort. Non-pharmacological management should have primacy in the management of most delirium. But when that delirium is an indicator of impending end of life, the role of pharmacology changes, partially at least dependent on the first point, the patient's and the family's wishes about management of this phase. But we're much more comfortable and much more ethical in use of doses of psychotropic medications, sedatives, and analgesics when we know a person is in the process of dying. We try and avoid it when we don't think the delirium is going to be terminal. Despite this, there's very little data to guide practitioners on the use of psychotropic and sedative medications in people with dementia as towards the end of their life. Traditionally, haloperidol has been used for the management of agitation in palliative care. Much of that work came out of data from people with terminal complications of HIV/AIDS back in the 1980s and 90s. In older people, particularly in the general management of non-terminal delirium, the newer antipsychotics, the second generation antipsychotics such as olanzapine, quetiapine, and to a lesser extent risperidone tend to be preferred in older patients because older patients are much more vulnerable to the unwanted side effects of the older antipsychotics such as haloperidol. So we've got a setting where an agent such as haloperidol has traditionally been used in palliative care. It may not be the agent of choice for people with dementia experiencing a terminal agitation, but we have very little data to guide us. We do know that sedation is required in a significant proportion of patients as they do near the end of their life, and that discussion with family around the side effects of sedation perhaps outweighing, or the benefits of sedation in a particular case outweighing the risks of sedation, really needs to occur with the family. If we are to use sedatives, and again, these are general guidelines coming out of the BMJ in 2016, it's suggested that you use a short-term sedating agent to enable rapid titration. So some of the benzodiazepines, for example, differ from their counterparts in that they have wildly differing half-lives. Clonazepam, for example, which I believe is reasonably widespread use in palliative care, has a half-life in the elderly of 36 hours. Diazepam has a half-life of 50 hours in the elderly. So it's a very hard medication to titrate because you're always chasing your tail from the effect that you saw as far back as 2 days ago. In general, with these longer-acting benzodiazepines as well, in general, the longer acting a benzo is, the longer it takes to take effect. So if you're using clonazepam or diazepam as PRN medications, they probably won't have much effect for about an hour. If you use a shorter acting agent, the onset of action is much quicker as well, and you can give repeated doses. Doctors still tend to not like using benzodiazepines because of fear of addiction and or tolerance. And again, in the palliative care setting, fear of addiction is probably the least of your concerns. And even in the setting of severe dementia in a nursing home where a person's prognosis or expected duration of life, even in the absence of progressive dementia, is 2 years, you know, addiction is not something that we worry that much about in this setting for obvious reasons. Again, in terms of general palliative care guidelines, and this doesn't necessarily limit us to a discussion around dementia, these principles are pretty much universal, and I'm sure you're familiar with them in the palliative setting. There's a number of signs which in non-dementia conditions can be accurate predictors of end of life: the presence of agitation, chain stoking, altered conscious state, decreased ability to communicate, loss of appetite, increasing fatigue, loss of mobility. In cancer-related and non-neurological conditions, these signs are potentially discriminative. In dementia, you know, virtually all of these, perhaps with the possible exception of chain stoking, part and parcel of the course of somebody as dementia progresses anyway. You know, towards the end of dementia, people lose the capacity to swallow and protect their airway. They get less hungry because they're less mobile. You know, that deterioration in function is part of the course in dementia. It's expected. So these symptoms become non-discriminative. We've mentioned the change in conscious state as not being discriminative either in the setting of dementia, because these people are so prone to delirium that is non-terminal. The general principles, if somebody is showing signs of anxiety, delirium, and agitation, is to look for a cause. As I said earlier, we may not find one in up to 40% of cases. It doesn't mean that that isn't a cause. It just means that we can't find it. And presumably in the cohort who then go on to pass away in short order, the cause only becomes obvious in retrospect. They've become agitated because they've got a terminal agitation rather than an iatrogenic delirium or one that's been induced by an infection. Benzodiazepines as trials and antipsychotics as trials are recommended for use within the NICE guidelines towards the end of life. But as I say, when we're managing people with an uncomplicated dementia, we try and avoid these drugs. So that's the need to recognize the dying process so that our mindset can change. So to make this point again, you know, we've got all these predictors in non-dementia conditions of impending death, but in dementia, decreased mobility, Increasing withdrawal, the presence of agitation and other behavioural symptoms may occur many months before the last week of life. The majority of those in care, as we've mentioned, are likely to be in the last 2 years of their life anyway. We know that severe frailty in and of itself, regardless of the presence of dementia, has a very high 12-month mortality approaching 50%. And we know that in the light of limited prognosis and very high 6-month mortality rates, sending people recurrently to hospital in the last year of their life is likely to be futile, and the goals of any admission in that setting needs to be carefully considered. And the same is true for people with dementia. We certainly see that they are commonly sent to the emergency department because a nursing home can't manage them. The hospital is not interested in trying to differentiate whether this is a terminal delirium, BPSD, or a non-terminal delirium. They just load them up with haloperidol and send them back. So in fact, the presence of recurrent hospital admissions, within the previous 3 months is one of the indicators that we're using in our DSA pilot as a potential indicator to show us that palliative care may well be appropriate. All of this, the uncertain prognosis of dementia, the difficulty in assessing when end of life is approaching, underlines the importance of having advanced care plans discussed with the decision makers of everybody who's in long-term care, but even more importantly, those who are likely, by virtue of their advanced dementia or the recent occurrence of one of these sentinel clinical events, fractured hip, febrile episode, pneumonia, to have their advanced care plans up to date and in place, because that may well help avoid these otherwise unnecessary admissions to hospital. So I've talked about the difficulties, we've talked about why it's so hard. Is there anything that can actually help us identify indicators of the need for end-of-life care in the setting of dementia? There are a couple of tools out there with varying degrees of applicability. We mentioned the work of Mitchell before. He's done some work in this area, as we've mentioned. His study of over 300 nursing home patients found that there was a 55% mortality at 18 months, and the median survival of the group that he followed was 1.3 years. What that tells us is that there's a very large group of people who lasted less than 2 years, and a smaller group of people who lasted, longer than that period of time, and that dilutes out the tail of the bell-shaped curve, if you like. But overall, median survival 1.3 years. Over an 18-month period, very high proportions of people with advanced dementia had pneumonia, febrile episodes, and eating problems. And we've mentioned the mortality rates after the occurrence of these 3 sentinel events. Surprisingly, perhaps, they found that other major causes of acute illness, such as a hip fracture or a myocardial infarct or a stroke, were actually rare in the last 3 months of life. But when they did happen, for example, we've discussed hip fractures, the occurrence of hip fracture was then very strongly associated with death within the next 6 months. So Mitchell went on to try and develop what he referred to as the ADEPT tool. It's always nice to have a good acronym, but the Advanced Dementia Prognostic Tool was developed by Mitchell on the strength of his work. This was a 12-item additive scale that includes demographic information, age, gender, level of functional dependence, their nutritional status, presence or absence of various physical symptoms and medical conditions such as congestive cardiac failure and shortness of breath. He tried to validate this tool in a prospective study of over 600 nursing home residents with advanced dementia. Unfortunately, the ADEPT tool was great at telling him which patients weren't going to die, but it wasn't great at telling him which patients were going to die. So it had a sensitivity of only 27% for predicting death within 6 months. And obviously within particularly an inpatient palliative care setting, you can't afford to sit on people for 6 months, at which point they may not die anyway. Your services would be clogged with false positives. We do know that agitation is very common as a symptom in the last weeks or months of life, And when combined with other physical symptoms, such as the presence of pain, such as the presence of shortness of breath, that does increase the positive predictive value of agitation as a predictor of death in the presence of dementia. Guidelines around terminal agitation. I think this is from the Hospice of Cincinnati from memory. Again, we're deviating briefly from dementia to go back to terminal agitation in association with any end-of-life symptom. You look at the behavioural symptoms there: agitation, anxiety, distress, restlessness, sleep issues, verbalizations. You know, these are part and parcel of behaviours that we see in dementia. So they're not valid predictors of impending death or the need for palliative care in dementia, but it just illustrates the sort of behaviours that we see routinely and why that they are not useful when applied to people living with dementia approaching the end of life. Another researcher called Amanoff proposed in 2004 the initiation of what he called relief of suffering units in general hospitals. And as part of his development of this proposal, he developed something that he referred to as the MSSE, not to be confused with the MMSE, the Mini Mental State Examination, but the Mini Suffering State Examination. What Amanoff did was he looked at 12 variables on the MSSE in the presence of people with dementia, and tried to use a high score on this scale as a predictor of the need for palliative care, using the degree of suffering experienced by the person living with dementia as a proxy indicator for that need. So the indicators that he chose in no particular order: somebody not being calm, presumably agitated; the presence of screaming, which is a fairly obvious indicator of distress and suffering, I would have thought; the expression of pain, the presence of decubitus ulcers, malnutrition, eating disorders, having had some invasive medical procedure done to you, because that's not pleasant either; the opinion of the doctor as to whether the patient is suffering or not; the presence of an unstable medical condition; and the opinion of the family about whether the person is suffering or not. And depending on what you scored on this scale, he tried to delegate people into 3 different groups: the low suffering group, the intermediate suffering group, and the high suffering group. And he found that when he did this, there was a correlation between the degree of suffering that was present in someone with dementia and their life expectancy. You see in the low suffering group, 134 consecutive patients who survived less than 6 months. The low suffering group had an average survival of nearly 58 days. The intermediate suffering group survived on average for 45 days. And those who were suffering a lot, who scored the highest, had a mean survival of under a month with very high significance levels. So perhaps this mini suffering state examination could be used as a predictor for who to refer to palliative care services as well. These relief of suffering units that Amanoff proposed, they acknowledge in their model of care that they may still get it wrong. You know, this is not an exact science. Some people do bounce back against all expectations, but these units that Amanoff proposed was that they should be located within existing hospitals, perhaps in a dedicated ward. They should cater for the needs of those with an end-stage dementia, whose care in general hospital settings tends to be spread across a variety of different units, usually with each unit trying to turf the patient off to another unit. You know, try and send them to a medical ward if they've got a surgical problem and they're post-operative. You know, nobody really wants to take ownership of this really very difficult patient group, particularly if they have behavioural disturbance. So he proposed these specific units whereby an entry criteria for admission would be a high suffering score. They acknowledge that they may get it wrong and that those who improve could be discharged back to long-term care. So that's a potential model that could be implicated in acute hospital settings to try and manage this group better. There are some other tools out there. There's the so-called Reach Out in Dementia Toolkit. REACH is another acronym for Recognise End of Life and Care Holistically. The verbal gymnastics we go through to get a good acronym. The REACH Toolkit does enable us, it's hoped to identify evidence-based symptoms and signs about the approaching end-of-life stage in people living with dementia. It has been piloted and been shown to have demonstrated usefulness in residential aged care facility settings, and it emphasises the presence of 8 signs and symptoms, the presence of one or more of which can indicate the need to change to palliative care. And they're listed there, you know, full dependency in ADLs, dual incontinence, verbal communication impaired, feeding difficulties, and so on. But again, you know, in the presence of severe dementia, most people with severe dementia and significant cognitive impairment are going to be some degree physically dependent along this scale. But it does act as a prompt for those discussions about end-of-life care and advanced care planning, even if it doesn't enable us to identify in and of itself that group who are going to die imminently. I think that concludes my prepared remarks, other than to emphasize that most people who have dementia won't actually die from it. You know, most people with dementia will more commonly die of other conditions, other coexisting illnesses or comorbidities, whose presence will worsen the agitation and distress that we see in dementia. So most people die with dementia rather than dying from it, and that we shouldn't exclude the possibility of very real physical pathology on that basis just because somebody has a severe dementia. You know, we need to realize that people living with dementia have other things going on with them as well, which can and do lead to death, and dementia is simply a complicating factor. After that lengthy rambling monologue, I'll pause for any questions, comments, or abuse.
What a lot of information, and you know, your passion for your subject has come through beautifully, Steve. Thank you so much. We have a few questions, and I will be closing off at 8:30 so everybody can get on with their morning. The first question came in quite early on. Is there any data that indicates what percentage of people with dementia die at home?
Okay, very good question. The short answer is no, but there are some proxies that might help us. You know, the very final slide that we showed indicates that most people with dementia actually die of something else, because the biggest single risk factor for dementia is old age, and old people tend to have a lot of stuff wrong with them. So there are many people with dementia who die at home, but they probably die from heart disease, stroke, you know, sudden acute medical problems, or in receipt of palliative care for those medical problems, rather than dying at home from dementia. You know, to die from dementia rather than with dementia, you know, you're pretty much in need of high-level full-time nursing care before dementia gets to that stage. So I would presume that very few people with very severe and advanced dementia die at home, simply because their care requires 24-hour nursing assistance. And if they have significant behavioural disturbances as well, that's often, you know, beyond the abilities of a single elderly carer to cope with. So I hope that answers the question in some way.
That makes sense, doesn't it? Another question. We often use tools like AKPS, the Australian Modified Karnofsky Performance Status, or PPS, the Palliative Performance Scale, in palliative care, but perhaps not so useful in dementia. The question is, do you think the FAST dementia scale is useful to help indicate if people with dementia are moving closer to life, closer to the end of life? Sorry. I think.
Look, sure, fast staging can be useful, certainly to inform, you know, how advanced the dementia is. It's not particularly, well, it's not good at all, as far as I know, for predicting imminent end of life. You know, fast dementia staging, it's mainly the geriatricians who use it. I mean, I'm familiar with it as an aged psychiatrist, but I don't use it myself. But, if you're very highly dependent on the fast scale, all it means is that you're bed bound, you need assistance with transfers, you need assistance with feeding, you're incontinent. Those are all signs of severe dementia. But, the prognosis of severe dementia is the question in relation to palliative care services. Somebody can have severe dementia and with good nursing care still live for 3 years. So it certainly tells you that you're close to the end of your course with dementia as an illness, but it says nothing about impending imminent death, if you see the distinction.
Sure. What pharmacological methods do you use?
Okay, well, there's DSA in general and our approach to dementia-related behaviours. That approach is valid for dementia. I did mention that about 13% of our cases have delirium as a complicating factor. Fortunately, the non-pharma approach for delirium and dementia are pretty much identical. Our approach is dependent on, finding a symptom and not treating the symptom as a diagnosis. That's the first point. The commonest symptom that prompts referral to DSA is the presence of agitation. And agitation, a general practitioner may see agitation and see that as being an indication for an antipsychotic. That's like going to your GP with a cough and saying that the cough is an indication for an antibiotic. It's not. There's many different causes of cough and they all require different treatments. We try and identify the cause of the agitation and direct treatments towards that. So that's the general principle. If we identify that delirium is one of the contributing causes, the general principles of non-pharmacological management in delirium are a quiet, low stimulus environment that is well lit so that the person's got more information to orient themselves to their environment. A quiet room, the use of regular and predictable care staff so that it's not a different person for each patient on each shift. And in particular, trying to avoid the use of agency staff who don't know the patient. We know that even in the presence of delirium, people have long-standing pre-existing likes and dislikes, which should be catered to. We find that carer approach is a particularly frequent aggravating factor in dementias, in behaviours, whether they're related to dementia or delirium. We find that unrecognised pain is a significant contributor in about 60% of our cases as well. And I know the thrust of the question was non-pharma management, but we do overlook the non-pharmacological management of pain as well in this group. We tend to resort to pills, often opiates with a central mode of action, which can in fact make the confusion worse. So we try and use non-pharma pain management such as massage, heat, counter-irritation and so forth as well. Again, a long rambling answer, but I hope it gives you some sense of the principles that we employ.
That sounds good, thank you. Wayne says, we have been reviewing the National Palliative Care Referral Guidelines in New Zealand, and there is a question about the accuracy of the surprise question, especially in non-cancer patients. Will your study provide any evidence on the usefulness or accuracy of this surprise question?
It will, at least we hope it will. The pilot that we've constructed, we've picked items from various tools, from the work of various researchers, including Amanoff and Mitchell, and we've piloted a number of indicators that we think may be relevant, one of which is the surprise question. So when one of our dementia consultants is considering could this be terminal agitation, they are required to answer the surprise question. So that gets recorded. When the pilot concludes, we'll be able to have a look and see which of those particular indicators that have face validity for being predictive of terminal agitation actually hold true in this group. So yeah, we'll have some data on the surprise question. The pilot that I'm talking about, by the way, it's a 12-month pilot and it's due to conclude towards the end of next month. So hopefully we might have some data to share with the group later in the year once we've had a chance to analyse it. And if it holds together, we'll probably try and implement it as an enduring part of our service.
That sounds useful, thank you. As you noted, a lot of hospices are not staffed for or expert at having inpatients with severe BPSD, and often that environmental continuity is important. rather like you have for your trial, perhaps the answer is to bring palliative care staff into your teams rather than sending the patients to palliative care. Can you comment on how that model is progressing so far?
Look, I quite agree with Vicky's observation there. You know, I think if I were in the final stages of my life, I would rather be managed in situ, whether that's in my home or in a nursing home, rather than go off to a specialist palliative care service. You know, the sheer number of people who are going to be affected by, you know, terminal agitation and end-of-life issues and dementia is so vast that you couldn't admit everybody to an inpatient setting anyway. I really do think that in the case of advanced dementia, it is better if people receive end-of-life care in their nursing home. But still, it's very hard to engage local palliative care services to do that for somebody with dementia. They're used to going to people's homes. They're used to providing palliative care in nursing homes for a variety of other conditions, but they're not used to providing palliative care where dementia is the impending cause of death. How the model's progressing so far, we've probably had about 50 of our referrals move to the palliative care pathway during the pilot. You've got to be careful when doing this stuff because you don't want to overcall impending death because it's a big decision. It's a big call to make. So we're probably still under-recognizing many people who do go on and die within 3 months of their case closed. You know, if the number was 30% before and we've only had 50 patients through the pilot, of course we're going to miss some, but we'd rather undercall it at this stage rather than overcall it. Of the 50 or so patients who are in the pilot, there's been very few false positives. About half of them, I think, have been accepted by local palliative care services, either as outreach or admissions. The remainder have tended to be in rural, regional and remote settings or in settings where palliative care services are frankly overloaded. And some of those patients are accessing our palliative care physician who's on staff liaising directly with the GP. But as I say, we'll have full data towards the end of the year.
Thank you. We're running out of time, so just the final question. What guidance can you give on ensuring that advanced care planning is patient-led in dementia?
Okay, thanks, Sean. It's certainly very important. And, you know, I used to, in earlier iterations of my career, work in memory clinics. So, you know, the setting where you actually diagnose dementia. And still in my private practice, I do a lot of diagnosis. And to me, you know, the best time for patient-led input into advanced care planning is around the time of diagnosis. Because if you leave things until the stage where somebody has advanced dementia, you know, so advanced that they've actually been moved into residential aged care, it's almost certain at that stage that the person themselves are going to be too advanced to have meaningful input into their end-of-life directives at that time. But at the point of diagnosis where things are mild and the person still has the capacity to think about those things, that's the best time to do it. And, you know, for any other condition, the point of entry into residential aged care is usually a pretty good time to do it because we know that the average life expectancy, regardless of what you've got, is about 2 years at that point. Having said that, you know, we tried to do a pilot in our publicly funded memory clinic about getting people to do advanced care directives whilst they were within the diagnostic service. And despite, you know, large amounts of support for them to do it, only about 10% actually did. So maybe they're too confronted by the diagnosis in that early stage to give reasonable thought to it. You know, maybe there's a middle ground between the point of diagnosis and severe dementia where capacity is still retained, where the person has the ability to have meaningful input into their care. But, you know, in an ideal world, that advanced care directive should be done as early as possible to ensure that it's patient-led as much as possible. Thank
you, Steve. Now it's time to call the meeting to a close. I just want to thank you again, Steve. That's been very much appreciated. I can tell by all the comments that have come through. And thank you, everybody, for joining us today. I'll close the meeting.
Thank you.